Hi everyone, Nurse Jenny here from Nurse Life Academy, and I will be reviewing questions and concepts related to hematology that you must know for the CCRN exam. I will time mark this video, so feel free to just scroll through at your own pace, but I do give extra information and explanations after every question to really reinforce the content. Without further ado, let's get to it. Question number 1. Your patient has a platelet count of 100,000. You know that this is blank, and the assessment finding you will most likely see is blank. A, normal and an elevated fibrinogen. B, normal and splenomegaly. C, abnormal and a decreased level of consciousness. Or D, abnormal and petechiae and ecchymosis. And the answer here is D. A platelet count of 100,000 is abnormal, and the assessment finding that you will most likely see will be petechiae and ecchymosis. Let's talk quickly about platelets and thrombocytopenia. So platelets are the smallest type of blood cell, and they are essential for clotting. And a normal platelet count is 150,000 to 400,000. So we classify thrombocytopenia as platelets less than 150,000. And platelet count is a measure of platelet quantity. To get more information about platelet function and how well platelets are working, we would look at the bleeding time, but the platelet count is only a measure of platelet quantity. And when a patient is thrombocytopenic, you will most likely see petechiae and ecchymosis due to the lack of ability to clot normally. There are situations in which platelets can have impaired function, such as with sepsis or DIC or inflammation. And there are also medications which impair platelet function, such as aspirin, clopidogrel or Plavix, prasugrel, heparin, or alteplase, just to name a few. Most of the time, we use these medications to impair platelet function on purpose. So if someone has a cardiac stent or a carotid stent, these medications are important so that platelets don't aggregate and create clots. So now that we know a little bit about platelets, let's take it a step further and talk about their clotting factor friends. So I know this looks scary, and I'm just going to talk about a few big points here. You do not need to memorize this. So very simply put, our body is full of blood, and blood is a river of living tissue which needs to know when to be liquid and when to be solid, or when to clot. And when there's an injury or damage to a blood vessel, our body is smart, and it triggers this coagulation response to send over both platelets and clotting factors to the site of injury, and that helps stop bleeding and help form a clot. And the clotting factors that I'm talking about here, they're included in the coagulation pathway on the left-hand side. You don't need to memorize this again, but you do have to know that these clotting factor proteins are activated when there is an injury, and that clotting factors work with platelets to form a clot. So that's all that you really need to know here. When there's an injury, your body sends both platelets and clotting factors to the site of injury to form a clot. You can see here I identified where Coumadin and heparin act on in the coagulation pathway, and that's really just for a visual representation so that you can see that these medications work on the pathway and they prevent it from going on to form a clot. You don't need to know exactly what clotting factor they act on, it's just for reference. So our body does a great job forming clots, but it also does a good job naturally breaking down clots when needed. And when the body senses that it needs to break down a clot, there's a protein called plasmin which comes on over and it breaks down the clot, and it leads to the formation of fibrin split products. We'll go over fibrin split products when we cover DIC, but what you really need to know is that when a blood clot breaks down, it ends up forming fibrin split products. Question number 2. Which of the following laboratory findings are most specifically indicative of disseminated intravascular coagulation, or DIC, as the cause of bleeding? Is it A, elevated fibrin split products and D-dimer, B, elevated PT, PTT, and INR, C, decreased platelet count, or D, decreased hemoglobin and hematocrit? The answer here is A, elevated fibrin split products and D-dimer. Although all of these could be correct, the question is asking for the most specific, which is indicative of DIC, and that would make the correct answer A. Question number 3. You suspect DIC in your patient. Which of the following lab values would be consistent with this diagnosis? Is it A, decreased platelets, increased fibrinogen, and decreased D-dimer? B, decreased platelets, decreased fibrinogen, and increased D-dimer? C, increased platelets, increased fibrinogen, and increased D-dimer? Or D, increased platelets, decreased fibrinogen, and increased D-dimer? And the answer here is B, decreased platelets, decreased fibrinogen, and an increased D-dimer. As promised, we will talk about DIC, or disseminated intravascular coagulation. So DIC is a state of hypercoagulation that is always secondary to another problem. And this problem can be some kind of big inflammatory response or endothelial damage, such as sepsis or trauma or an obstetrics emergency, which can all lead to DIC. And because of this endothelial damage, microvascular clots form. So if you remember back to one of our first slides, when there is an injury, platelets and clotting factors are going to the site of injury in order to form these clots. And at the same time, the body is like, what in the world is going on, and why am I making all of these microclots? I want to get rid of them. So it sends other proteins to break down those clots. And when a clot breaks down, it leads to what? Fibrin split products. That's right. So in DIC, your body is going haywire because it's making all of these clots because of the endothelial damage, but it's also trying to break them all down too. So at a certain point, you use up all of your clotting factors from making all of these microclots, and then you just start bleeding because you have no clotting factors left. And this is the hallmark of DIC. It is a clotting problem, and it's not a bleeding problem. Some clinical signs that you'll see will be bleeding from multiple sites of the body and ecchymosis. And as far as labs go, these are a must to memorize. You will see a decreased platelet count, decreased fibrinogen, decreased hematocrit and hemoglobin. You will see an increase in fibrin split products. Why? Because your body is breaking down those microvascular clots, and elevated fibrin split products are the definitive lab test that indicates the presence of DIC. You will have an increased PT, PTT, and INR due to consumption of these clotting factors. And lastly, you will have an elevated D-dimer. D-dimer is a non-specific test, but it tells us that there is clotting somewhere. So it's not a definitive test, but it will be elevated in DIC. Our treatment is going to be, of course, as always, treating the cause if able, and we will also administer vitamin K, FFP, cryo, and platelets as needed. Question number 4. How would you reverse bleeding with low fibrinogen? Is it A, cryoprecipitate, B, protamine sulfate, C, vitamin K, or D, fresh frozen plasma? And the answer here is A, cryoprecipitate. So cryoprecipitate can be considered liquid fibrinogen. And a low fibrinogen level is usually less than 125 or even 100. And in that case, if you have a low fibrinogen with bleeding, you will be replacing that with cryo. Question number 5. The most effective reversal for warfarin is A, enoxaparin, B, cryoprecipitate, C, vitamin K, or D, protamine sulfate. The answer here is C, vitamin K is the reversal for warfarin. Question number 6. The most effective reversal for heparin is A, protamine sulfate, B, vitamin K, C, fresh frozen plasma, or D, cryoprecipitate. The answer here is A, protamine sulfate is the reversal for heparin. So I listed all of these here in a chart, and you have to memorize the reversals here. No ifs, ands, or buts about it. Just sit down, memorize them, make flashcards, whatever you need to. I do have a couple ways to remember what is the reversal for what. As far as heparin goes, heparin and protamine sulfate both have P's, so the reversal for heparin is protamine sulfate. For Coumadin, Coumadin sounds like it maybe is spelled with a K, so the reversal is vitamin K as well as FFP. And lastly, if you have bleeding with low fibrinogen, remember cryo or cryoprecipitate, it is liquid fibrinogen. Question number 7. 2 days after admission for a pulmonary embolism, the patient's laboratory report reveals a 55% decrease in the platelet count and no clinical changes. Which of the following is indicated first? A, infuse platelets. B, discontinue all heparin exposure. C, check heparin antibody presence using an ELISA test. Or D, start a direct thrombin inhibitor. The answer is B, discontinue all heparin exposure. So this patient would have had heparin as part of his treatment for his PE, and he does have signs of heparin-induced thrombocytopenia. So the first intervention is to stop all heparin to prevent progression of the problem. Infusing platelets is only indicated for active bleeding or extremely low platelet counts of less than 10,000. Although a heparin antibody test would be important, it wouldn't be your first intervention. Same with starting a direct thrombin inhibitor such as argatroban. It will be needed, but the primary intervention is going to be to stop your heparin first. Heparin-induced thrombocytopenia, or HIT, is due to an immune and antibody-mediated response after clinical exposure to heparin. And what happens is that your immune system causes your platelets to clot in the presence of heparin instead of doing its job, which is to prevent clots. So HIT also causes your immune system to make these antibodies that activate the platelets. So this is why your platelet levels drop and why patients can have life-threatening clots due to HIT. Some clinical signs you'll see include petechiae, a platelet decrease to less than 150,000 or a drop in platelet count by 30 to 50%, and you can have systemic thromboses such as DVTs, PEs, or strokes. Discontinuing all forms of heparin is going to be our number one priority. That includes infusions, subcutaneous heparin, heparin flushes, and even heparin-coated catheters if you have those. These patients need anticoagulation since they're at such high risk for developing systemic clots, so we will start them on a direct thrombin inhibitor such as argatroban for their anticoagulation. We can test for heparin antibodies, and if platelet count is less than 10,000, make sure to watch out for a change in the level of consciousness, as patients can develop spontaneous intracranial hemorrhage. Question number 8. A patient required 6 units of PRBCs for GI bleeding status post ruptured esophageal varices. Which of the following electrolytes do you anticipate replacing? Is it A, potassium, B, magnesium, C, calcium, or D, phosphate? And the answer is C, calcium. So banked blood contains citrate, which binds to calcium, so it'll get rid of that calcium. And for every about 3 units or so of blood, you should anticipate giving 1 gram of calcium. Question number 9. You began a blood transfusion on your patient 5 minutes ago, and she suddenly develops shortness of breath and chest pain. Which of the following actions should be taken initially? A. Complete a 12-lead EKG and a troponin. B. Immediately stop the transfusion and recheck vital signs. C. Infuse 1 liter normal saline bolus and complete a 12-lead EKG. Or D. Get a stat chest x-ray. And the correct answer here is B. You want to immediately stop the transfusion and recheck vital signs. So we'll talk about blood transfusion reactions a little bit. There's 2 different kinds, either an acute transfusion reaction, which occurs within 24 hours of blood product administration, or a delayed transfusion reaction, which occurs after 24 hours of blood product administration. And these transfusion reactions are usually due to human error or ABO incompatibility. Patients who experience a transfusion reaction can develop fever, either tachycardia or bradycardia, hypotension, chest pain, dyspnea, low back pain, rash or pruritus, and even blood in the urine. This is why it is so important to stay in the room with them for the first 15 minutes of their blood transfusion and to keep monitoring them even after the transfusion's been completed, because you could have that delayed transfusion reaction. If your patient starts developing some of these signs and symptoms, your first priority is going to be to stop the transfusion immediately and disconnect the blood tubing and infuse normal saline. You absolutely also want to assess the patient and monitor their vital signs right away. And then you want to send the blood product to the blood bank and notify them of the transfusion reaction. Question number 10. You are caring for a patient whose labs are the following: hematocrit of 28, platelets of 12,000, fibrinogen of 92, INR of 2.2, PTT of 36, PT of 14. DIC is suspected. Which of the following would be the most appropriate for this patient? Is it A, administer glucocorticoids, B, transfuse platelets and cryoprecipitate, C, start a heparin infusion, or D, PRBC transfusion? The answer here is B, transfuse platelets and cryoprecipitate. So you have a pretty low platelet count. It's not less than 10,000, but it is 12,000. So you want to give some platelets, and then your fibrinogen is low as well. It's less than 100. Remember, you want to think of cryo as liquid fibrinogen. Question number 11. 2 hours after a complicated premature delivery with placenta abruption, the nurse notes that the puncture wound from the patient's recent venipuncture is continuously bleeding. Which laboratory tests should the nurse anticipate obtaining? A, ionized calcium and Pitocin levels, B, prothrombin time and D-dimer, C, fibrin split products and magnesium, or D, D-dimer and factor IX assay. And the answer here is B, prothrombin time and D-dimer. So a patient with an obstetrics emergency is at risk for developing DIC. And I wanted to put this question on here because it tries to trick you. I know that we talked earlier about fibrin split products being the definitive test for DIC. However, there is no reason to obtain a magnesium level as it has nothing to do with DIC. So the correct answer here, which can tell you more information about whether or not this patient is in DIC, would be B, prothrombin time and D-dimer. Of course, you would want to get a full CBC with platelet count and a fibrinogen level and fibrin split product count as well, but the best answer here is going to be B. So when you guys take these questions, make sure that both parts, or if there's three, make sure all three parts of the answer choice are correct. Question number 12. A patient is receiving a heparin infusion, status post-pulmonary embolism. The latest lab results reveal a sudden drop in the platelet count to 80,000 from 280,000 the previous day. The nurse would anticipate receiving which of the following physician orders? A, begin an argatroban infusion. B, hold all anticoagulants. C, infuse platelets. Or D, continue heparin and order labs for heparin antibodies. The answer here is A, begin an argatroban infusion. So this patient most likely developed heparin-induced thrombocytopenia, and a direct thrombin inhibitor needs to be started. Most importantly, heparin needs to be immediately discontinued, but B is not the right answer because you don't want to hold all anticoagulation. You do want that argatroban for this patient because of that pulmonary embolus. It doesn't look like in this scenario the patient has life-threatening bleeding or their platelet count is less than 10,000. All right, guys, we have made it to the end. I know this one was a little bit more of a shorty, but there really is only 3 to 4 hematology questions on the CCRN, so I'd rather you guys spend a lot more time focusing on the other sections. If you liked this video or found it helpful, please like and subscribe to my channel and let me know if you have any questions. I would be more than happy to help. If you're taking your CCRN anytime soon, good luck. You absolutely can do this. Thank you everyone for watching. Nurse Jenny signing off for Nurse Life Academy. Have a good one.